Thank you guys for braving the rain today. I think it's hilarious that the rain seems dangerous here. I'm from New York. The other thing I just want to comment on, Gigi, I have a 10-year-old boy, and the founder of Roblox is my nemesis. He has ruined my family life. My child is on Roblox all the time. He creates games. But you know, Roblox had a market cap of what, like $30 million or something in February of 2020. By June of 2020, after 3 months of COVID, it had a market cap of like 180 million, and then went public and then became like, you know, exponentially more valuable. So he did well. Okay. I hope they're all addicted to Roblox like mine. So I'm actually so happy to be here. I have been following the Changemaker program for a little while, and Rich Lyons is a really good friend of my family's, and I've just been so excited to watch what he's done here. And I think in public health especially, we need change, and so we're going to need change makers, and we need people who can manage change and communicate about change and lead change. And I can tell you right now, and my colleague Rachel is here, I'm trying to manage a lot of change, but I'm not communicating about it very well because it's really hard to communicate about change. So I'll talk a little bit more about that, and I'm going to hand the floor to Rachel, who, by the way, runs the JSI office here in Berkeley and is hiring. She can tell you in a second. So I want to start. Gigi told me that there was an element to this about a personal journey. So, and I wanted to tell you just a little bit about what I think change making is about and why, one of the reasons that I've thought it's so compelling. So many of you have probably heard this. The Echoing Grain Foundation talks about the moment of obligation. And the moment of obligation is a moment when you kind of feel compelled to act. It doesn't have to be a big deal. It doesn't have to be dramatic, but it's some time in your life where you really realized I can make a difference and I want to make a difference for, you know, some reason, something occurred to you, somebody said something, you saw somebody that really moved you in some way. So I'm going to tell you about my moment of obligation. And then I'm going to tell you just a little bit about a couple of jobs that I've had and a little bit about my journey. It's been super circuitous. I don't believe you ever get pigeonholed in any kind of job or any field. I think that you learn something from each role and bring it to the next. So I was going to tell you a few things about a couple of different jobs, and then end with, there's no way I could talk about everything that JSI does, but I thought I'd talk about a couple of ways that I think we really have some innovative technology and expertise that are really core to the work that we do. So I'm starting with this slide. This slide is a picture from a newspaper. It's fuzzy on purpose. That's kind of part of the shtick. It's from 1995. It's a ferry in Indonesia. It was originally, I think, from Malaysia. It was brought to Indonesia to go from the very, very tip, the northwesternmost tip of Indonesia on Sumatra, to an island about 4 hours away called Pulau Wei. And in January of 1996, it sunk. And I was on it when it sunk. And it was the Friday before Ramadan. Indonesia is the largest Muslim nation in the world by population. And Ramadan, of course, is the fasting month. So on Monday, Ramadan started. And on Friday, it was the weekend that everybody got together with their families and they traveled to be with each other and have big feasts and a celebration before a month of fasting. So the maximum capacity of this ferry was 220, but conveniently it doubled because more people needed to get there. So we need to double the capacity of the one boat that goes to the same island. So it was full. I was on it by myself. I was working for Save the Children. I graduated from college and I moved to Indonesia. I taught English for a few months and then I got a job with Save the Children, which wouldn't happen today because I didn't really have very many skills. I did speak English and I spoke English pretty well. So they had me writing reports in English and teaching the local language, which is really Bahasa Indonesia, which I knew, which was very easy. But mostly, I really didn't have very much public health or any public health experience, but they still gave me a job. And now I run an organization very similar to Save the Children, and we don't have those jobs anymore because we recognize that the local expertise is much more valuable than what I could have brought as an undergrad. So I got on this ferry, and it was my Bahasa, which is a very simple language to learn. Has anybody ever been to Indonesia and spoken Bahasa? Tough crowd. Oh, I forgot to tell you. Who's familiar with Myers-Briggs? Thank you. It's a little outdated. Myers-Briggs is a personality test. The first thing is whether you're an extrovert and an introvert. This is not if you're good at a party, which I am, but I'm a very, very, very big E, which means I need feedback from people. So I had a half an hour before this, and my job was to prepare my remarks for a half an hour. I had an office in California Hall next to the chancellor's office, and I can't do it because I'm sitting there alone in a room. I need feedback. Rachel sees this on Zoom. It's a nightmare and when people are all in masks, I'm like, are they smiling? Are they laughing? Are they sleeping? I don't know. Are they responding to what I say? So I need the feedback. And even in a small group, even just nod and tell me that you're like, it's okay. And if it's not, tell me that. So my E is very, very far. It's very helpful in my marriage because an E means that you need energy from people. And that's what makes you tick. That's what gives you energy, is being with people. If you're an I, an introvert, it doesn't mean you're not good at parties. You can be really good at parties, but then you really need to relax because it's terribly exhausting to be with other people. So it's really interesting. My husband's a total I. We come back from a party. I'm so energized because I've been with people, and he's exhausted. So right now, I can't stand working from home because I'm all alone and I'm not with people. It's terrible. I don't know what they're thinking on Zoom. So for some people, and I think this is really the future of work, we're going to have to figure out. No, he just has an Irish name.
Oh, I was like, how can you be an introvert when you're Irish?
He is not Irish, but he's called Rory. But he's not Irish. It's a super Irish name. Everybody thinks that.
So you guys, basically her message to you is,
don't leave me stranded.
We'll make this a conversation.
Yeah.
Okay? And you guys get more points. Yeah, one more excuse absence if you talk.
Oh my gosh. That feels so that's my disclaimer. So I'm on the ferry. I had moved to Indonesia. I'm working for Save the Children. I was working on women's literacy groups, which meant that we were teaching them Bahasa Indonesia, which again is a super simple language. It's the same alphabet as English. It actually is pronounced exactly the way it looks. And it's not there are 327 languages spoken in Indonesia, but Bahasa Indonesian is a blanket language for the whole country. In 1948, they adopted it, and it's a national language. Just to make something plural, you say it twice. There's no conjugation of verbs, so it's very simple. So I could teach Bahasa Indonesia languages to groups of women. This was pre-Asia crisis in the early 90s, so I'm dating myself. In the early 90s, the Asia crisis was in the late 90s, the big financial crisis. Totally pales in comparison to 2008, but it was a big deal at the time. And most of the women on these small islands in Indonesia where I worked, their husbands, brothers, fathers had all gone to other countries to work and send back revenue. So they were managing families, homes, crops, pottery businesses, children, everything. And they made time to come to these literacy lessons that I was privileged to teach. And I just remember thinking how resilient they were and how much they did with the little that they had, and how they could really, they mustered up all this energy to deal with really tough circumstances and really harsh living conditions. And so that was in my mind when I got on this boat to go away for the weekend on a 3-hour trip. So, and to date myself again, does anybody know Gilligan's Island? Long before you were born, thank you. Gilligan's Island had the song, A 3-Hour Tour, and then the boat sunk. And that's what happened on this. My brothers thought that was very funny at the time. It was a silly TV show back in like the 70s. So you can tell this boat was about to sink. They loaded on double the number of people that was supposed to be on there. And at 6 o'clock at night on the equator, so it was dark. It was about to get dark right about 6. It was delayed because they were piling more people on because more people had to get to the other island. And about an hour in, it started tipping. The big industry in the north of Sumatra is cement. And so they had dry cement in the bottom, but why wouldn't you? When the boat is, sort of a little bit low on the water, the cement got wet and it started to tip and then it turned over. And there were, we don't know, we'll never know the exact number, but we think it was 442 people on the boat and there were 41 survivors. And I was one of them. And I'm going to show you the picture quick. How do I do this, you guys? Oh, that's me. And I'm super swollen because I was in the water for 22 hours and I swam 33 miles and I was rescued at 4 o'clock the next day. And when you spend that much time in saltwater, I'm sunburned, I'm swollen, I couldn't talk because I had been in saltwater so much. I had to borrow clothes because I'd used my pants. I was a lifeguard in college. That was my high school and college job in the summer. So I took my pants off, I threw them over my head and made them blow up into a little sort of flotation device. And that's how I swam to shore, holding on to this little flotation device. On the boat, there were some life jackets. And all I remember was thinking, don't panic, get these life jackets to people because the worst thing you can do is panic in a situation like this. And so, yeah, I can't stand that picture. It's so awful, but it's from a newspaper. It was published all over the world on the front page of the Jakarta Post. And my mother was horrified. But this is just where Indonesia is. So if you see, this is the blue island all the way to the left is Sumatra. And the very northwestern tip was where this boat sunk. And if we had missed Pulau Way, the next thing is India and Sri Lanka. So, when I swam to a different island, or I floated, swam, ended up 33 miles away from where the ship sank. And the reason I tell this story is because what went through my head the whole time was those women who were given very little, still managing families, still raising children, still selling pottery, still have the time to meet with me, still have the time to support each other. I damn well can use what I've learned and all the privilege that I have to make sure that I survive. And I thought about all of the gifts that I'd had and why did I even know how to swim? Because I had a grandmother who threw me in a lake when I was 10 and she rowed a boat across the lake and made sure I knew how to swim because she was an empowered woman. She, of course, nobody thought that was weird that my grandmother knew how to swim and wanted her granddaughter to swim. I was a lifeguard in high school and college. That's a pretty privileged job to have. I had to take lessons to be a lifeguard. I was able to go to a lake where I was able to have this job. I got paid and I had spending money when I went to college. I was incredibly calm because I knew what I could do and I knew that I knew how to swim. And all of that privilege, really was my moment. Really thinking about that was my moment of obligation. And it doesn't have to be a dramatic thing, but for me, it wasn't the drama of the boat. It wasn't the drama of being rescued. It was really that realization that what I was given, and here I was in the middle of the ocean, the Indian Ocean, for many hours during the night, and the next day, thinking about how lucky I was and how fortunate I was. And so I really think to me, that's when I thought I'd like to be able to, grow older and say, I made some sort of difference. And I think you probably all have you're here because you've had some moment of obligation or you are open to that moment of obligation and you're really looking how to be a change maker and to make a difference. And so I started with that story because I wanted to make sure everybody was still awake. But I'm going to keep going. So you see Sumatra. You guys, I don't know how to do this. Yeah.
Tutorial. This goes
Well, and
forward.
where's it going? It's not clicking to that, right?
Yeah.
I'm pointing to that like there's a.
No. It's going to
Oh, okay.
a thing here.
Okay.
So you just click forward.
Okay.
Backward, and then this right here is the laser.
Oh, perfect. Okay.
Laser forward, backward.
Okay, so that's Indonesia. This is from CNN. And you can see where CNN said the ferry sunk. So I did that job. I stayed after a while. Once I was really sick, I had to get stitches on my legs. I had gotten stuck when the boat first went down, I wanted to get the life jackets out to people, and I leaned into the cabinet and got stuck in the life jacket cabinet and had to kick my way out. And I had big gashes in my legs, and they sewed it up with no anesthesia, and it was very painful. And they had to undo it. I had all this infection. And anyway, I stayed in Indonesia for another several months, and I came home. I ended up asking, I was working for Save the Children. The CEO of Save the Children at the time was like, who is this? Who was working in Indonesia? Had to get to know me pretty quickly because it was all over the news. And he took me under his wing. And I said, how do I get a job like yours? And he said, go to business school. And I wouldn't give this advice now. This is a while ago. But he said, we really need management skills. We need to know how to run a business, think about all of the business strategy. That's what we need in this field. So I went to business school. I ended up working for a while in the private sector. I worked for McKinsey for a little while. I wasn't very good at being a consultant, but I learned how they think. I was actually terrible at it, but I did learn how they think. And then, so I was working in the private sector for an education company in Hong Kong in 2004. When the 2004 tsunami happened, my maps aren't perfect, but you can see the center of the rings is exactly where the ferry went down. That's where the tsunami was in 2004. And so I was living in Hong Kong and working for this. I was Shanghai and Hong Kong. I lived in Shanghai during SARS. And
Margaret, what my son would say? You might be dead.
I know, right? Well,
I've lived in so many places where there was a terrorist attack. In Nice, in Paris.
Oh, I could go through my list. I was skipping most of them. But the SARS story, when COVID hit, I said to everybody, this is not my first rodeo. I know how this works. Of course I didn't. But, so anyways, I went back and I worked actually for Mercy Corps during the tsunami. I took a leave of absence from my job during the cleanup, the initial cleanup. But this place has a really, really, really strong place in my heart. And after that, I went back to New York for a little while. I ran Kaya just told me, I ran AFS, which is an exchange organization. If anybody's from the Midwest, no, most people aren't from it's the American Field Service. And it's an exchange organization where I had my best idea ever, I think, for a business idea. Totally failed, but it was still such a good idea about merging AFS with another organization, and it totally failed because we didn't communicate about it very well. So that's one of my big lessons in change management. So I'm going to skip now. Several jobs later. This is a map of New York City. African American Studies. I was the only white kid in the department. And you want to hear about privilege? I won the thesis prize. That's embarrassing. Residential segregation, which to my point. So several jobs later, I ran a mental health organization in New York City. And the dark parts, the darkest purple, are some of the highest financial poverty congressional districts in New York City. And that's where we ran programs. We put all the mental health services into schools, in the public schools. We ran community schools, which do wraparound community health services, linking with all the community, wraparound services, health services, food banks, and so forth. So those purple spots are where our schools were, highest poverty in New York City. But that's not what this map is. This map is actually a COVID map. So if you overlay my schools, it's exactly in those purple districts because that's where COVID hit the hardest. And I had a staff that 80% of whom identified as people of color, and 49% of them had COVID in the first 2 months because of where they lived. They lived in the neighborhoods that we served. They were in person the entire time. Nobody ever said no. And so this is in the first part of the pandemic in 2020. So I tell this story because I learned a ton from this job. We did mental health, but really what I learned here is that when we really understand neuroscience, we're going to change all of our interventions for poverty, financial poverty. And I think we're already starting to know that. We're starting to think about that more, in public health, in government programs. But the reason is, my goal in this job was always to look at the neuroscience part of it. So you see the brain on the left. And this is actually from an article from like our staunch competitor. I don't work there anymore. I never would have used it when I worked there, but they do really good work. So that's the brain. You see the neurons. You guys know enough about neuroscience that neurons, actually the hippocampus is one of the only parts of the brain that produces neurons. So the neurogenesis happens in the hippocampus, and stress actually cuts that off. And chronic stress, you know the difference between toxic and chronic stress? Chronic and toxic? Exactly. So toxic stress is, chronic stress is just what it sounds like. It's all the time stress, right? You're always under stress. But if it's buffered, and the best way to buffer stress is a relationship with another person, because stress causes cortisol, and relationships cause oxytocin, which is the love hormone. It makes you feel safe and calm, and that's what happens in your brain. Everything calms down. If your chronic stress becomes dangerous and unbuffered, it becomes toxic. And toxic stress is proven to have all sorts of health implications. So you're exponentially more likely to have all sorts of chronic health issues as an adult if you have toxic stress as a child. So diabetes, hypertension, heart disease, all sorts of mental health issues, substance abuse, all sorts of addiction things. So it's really, really important to recognize when chronic stress becomes toxic. So when chronic stress, the way it hurts, yeah. Yay, I love this.
Are there other ways to buffer stress?
Well, anything that calms you down, so obviously, you all know this, but relaxing, meditating, all sorts of mindfulness exercises, anything that slows your, your amygdala is where your stress response is regulated. So anything that you take deep breaths, you're mindful, but the instant you get a hug, it calms you down. And if that's sustained, if that buffering is sustained, you can actually start repairing the parts of the brain that have started to erode because of toxic stress. So my point in this, though, so the prefrontal cortex is where your executive functions are. It's how you behave. It's how you react. It's, your ability to regulate your emotions and to respond appropriately to somebody else. Your amygdala is where you regulate whether your stress response, and if you're in fight or fright, fight or flight mode. That happens in the amygdala. The hippocampus is where you store information and new learnings. And these are the 3 areas of the brain that toxic stress affects the most. So now if you think living in financial poverty causes toxic stress, right? And if you don't have an adult who makes you feel safe at home, at school, a neighbor, you're going to have chronic stress. And the 3 most important parts of the brain are how you act, how you behave, and how you learn. And now think of all the kids that get in trouble. Think of what the school to prison pipeline is. We're punishing children for acting out. In fact, that's probably the most appropriate response. But we have a presupposed notion of the way children should act. And if they're not following it, it's really a chemical thing in their brains often. And so if you think of who's affected most by toxic stress and poverty, start thinking about the interventions that we have in schools, how schools are run, how children are punished or rewarded. What happens if you do misbehave? You're taken away, you're taken out, you're taken away from the safety of being in a relationship with other people. So just think about the ways that we could really, if you're really thinking about the science behind stress and the science behind the school to prison pipeline, we would do things really differently. So that's what I worked on for a little while. The other thing that I learned in this job that is super important, and then I'm going to turn to JSI. So I said that 80% of our staff were people of color. And at one point I said, I'm a white woman of privilege. And my team was like, psst, that's redundant. And that was about 8 or 9 years ago. And that was a huge learning for me. And I didn't know, I was shy, if I said, I have this education and I'm, a white woman with, lots of privilege. And one day, one of my colleagues jumped up and said, own it and be an ally. And it gave me this safety to really be a vulnerable white leader of a staff, 80% of who were on the front lines before and during COVID, on the front lines of the worst poverty, financial poverty in New York City. And they brought me in, they let me in. And during COVID, they let me in. And so I would never, not only because you can see that map, but also because I had to learn my own way of acting, of being vulnerable, but also of showing leadership during a really turbulent time. And so I got to meet Isabel Wilkerson, who wrote Caste, and she actually let me in, and she tested me, and I said, your books. She wrote Caste, and she wrote The Warmth of Other Suns, and both of them are extraordinary books. The Warmth of Other Suns is about the Great Migration of Black people from the South to the North. It follows 3 stories: one out here to California, one to Illinois, to Chicago, and one to New York, and you really start to see all of the social constructions that affected the way Black people then settled in different parts of the country after the Great Migration. They were fleeing Jim Crow laws. So she then wrote another book called Caste, which, among other things, compares the United States to Nazi Germany and to the caste system in India, and actually tells us in the very first part of the book that the Nazis studied the American racist system to learn how to segregate and oppress another group. So the Nazis studied American society. So anyway, I think she's extraordinary. And I put that up there as sort of the pinnacle of this incredible learning that I had at this organization. So I was there for 10 years, and then it was time for me to leave because it was time for somebody who didn't look like me to take over. And that's when I came to JSI. So, which was only ready for me. I think that's fair to say. And it's an extraordinary organization. So this is where we work. It's an amazing scale and scope. JSI stands for Jon Snow. Anybody know who Jon Snow is? Don't say Game of Thrones. Who's the epidemiologist in the cholera epidemic in the 1860s in Victorian England. And he's the one who proved that the cholera was emanating from the Broad Street pump. And he finally took the handle off the pump so that people would stop drinking the water that was infected the well was infected, the Broad Street pump. So he was an extraordinary data scientist in his day. And JSI has been built on data and approaching public health issues but through data and really working toward health equity. Our mission is better health outcomes for all. So I was just going to give Rachel a minute because she walked here from our office just to talk for a second about some of the programs that we do. And she just is really an incredible leader in California, well, in the country, on health equity, especially on community health. Will you tell?
Sure.
And she's recruiting.
Can everybody hear me? Yeah. Okay. So my background is actually in health policy. We work at the Berkeley FD California office, which is located at Shattuck and Hudson, so very close by, on a slew of issues that I talk about as being at the nexus of public health and publicly funded healthcare. We try to help healthcare think about health the way public health folks do. In other words, about the social determinants of health, like Margaret's been referencing, the fact that only somewhere between 10 and 20% of your actual health outcomes are determined by medical care, and all the rest is determined by other things, like where you live, like your neighborhood, like where you breathe, like the poverty you grew up in, even like where your parents came from, the language you speak, all these other things. What percentage is it? They say it's about 20%, 10 to 20% are attributed to medical interventions, and then all the rest are these other things that actually influence health outcomes, right? And we also,
But where we put all our money?
especially in the United States, right? Insurance companies.
In the 20%.
Right. So we do a lot of work and it's research work, it's evaluation work, it's what we call training technical assistance or capacity building, depending on if you're coming from the domestic or international context. And we do policy development and implementation. And yes, we do use data, but a lot of that data comes from people. We do a lot of talking with people. We talk to providers. We talk to community members. We do interviews. We do group interviews or focus groups. And we analyze that information to make recommendations. And recommendations that we've made in the last 13 years since I joined JSI have included things like, hey, California Medi-Cal, you should really invest dollars in helping to make sure people who need housing have the ability to get into an apartment before you start doing care management and wraparound services. Because lo and behold, when folks are living below the poverty line, they don't have money to put a deposit down on an apartment. But there's medical dollars for care management for somebody who's living in permanent supportive housing. But there were no dollars available for actually setting up that apartment, staying in that apartment. You don't have to pay your bills. Things called tenancy support. So we did a bunch of research with primary care folks, public hospital folks, people working in behavioral health, public health, and we said, what's going wrong for people who are being cared for by the medical health system, by the behavioral health system? And they told us. And we listened, and we synthesized in that program that we made recommendations to the state of California on what's called whole person care. Pretty simple idea that people's behavioral health issues, physical health issues, social needs should actually all be taken into consideration when trying to get help out. And how many people know what a Medicaid waiver is? Okay, well, billions of dollars go to Medicaid waivers, where a state will say to the federal government, hey, federal government, guess what? We've got a better way of doing something than just paying for health services. And the federal government says, okay, make your case, show me that you're not going to spend any more money than you would have otherwise. And you can use the difference between what you say you're going to spend and what we would have spent. And you can in some of those gaps between the health system and behavioral health system and social services like so that's one example. You said 2021? Yes, so now you're like, oh no, it ended? Well, it's actually very exciting. A Medicaid waiver is also a demonstration, right? It's like a deal that the feds make with the state. Say, can you do it differently? And they hire some firm to do an evaluation of whether or not it works. Did it improve health outcomes? Did it actually save medical costs? Did it improve the experience of care for individuals? And if it works, then you can actually make it permanent. And so California now has a program called Community Support. You can look it up. It's part of the Medicaid program if you know anybody on that lists 14 different services that are now able to be paid for with healthcare money that are really not for healthcare services. They're for things like helping someone set up a home or staying in an apartment. And is this for everybody? No, it's not. It's for folks who are in very high risk groups, like people who are chronically homeless, people who suffer from severe mental illness. But these are folks who otherwise might be going to the emergency room all the time, rather than being cared for in a place that is a safe, more relaxing environment than an ER, or at worst a jail. Right? So community supports are now part of the California Medi-Cal program plans, health plans can pay for. And that's the way that they've been able to sustain this demonstration of this trial of whole person care as an example of a change that we've worked on.
And huge. Oh.
Sure. So we are bidding on a very big project that Kaiser is funding right now that is called Population Health Management Initiative. And it's a totally different program. We were not working with the on health care. We were working much more with the public hospital systems on the but yes, Kaiser is actually making a historic investment in community health centers over the next 2.5 years, and JSI is absolutely looking to be involved in that program.
We had the head of international programs for Kaiser Community speak on February 14th, and she's a Berkeley person.
Oh, wow.
And if you'd like to make an intro.
Sure. Certainly for Margaret. So you can notice I work in California, almost exclusively in California. Our office in Berkeley does mostly California-based work and some national work. But most of our international work is happening out of our DC, Boston, and ex officio offices in all of the countries that you see around.
And more out of those countries and not being run out of Boston. But one thing that is really important, I think, this is one of my pet peeves and a business opportunity for somebody. There is no way for all those social services providers to talk to the tertiary care hospitals and the big healthcare systems. We don't have language and databases and the same fields. They just can't talk to each other. And most of the best community-based organizations that are providing the best community-based care can barely work with a Kaiser or a big health system because there's no data flow. There's no API. There's no way for the systems to talk to each other. And it really means that the community-based organizations can't get paid for the work that they do. And so these types of programs are really, really important for the community-based organizations. So, okay, so I'll do a couple of, go ahead.
I kind of have a quick question. I don't know who would best address this question, but yeah, so you guys were talking a lot about like a whole person care model. What my kind of first thought, based on experiences that I've had as well as other stuff, is like what about the people providing the care as well? That's that's definitely really important for quality of care and making sure, especially like nurses, is a really great example when nurses work these really long shifts. So like, what have you guys done any projects helping the workers in the healthcare side of things rather than just people in health?
Yeah, certainly. Let's see, out of our office, I think one of the groups that's getting a lot of attention right now, and is actually an exciting opportunity in California, is community health workers. So these are traditionally not folks that went to medical school or to even nursing school, but nevertheless have a ability to help folks navigate the healthcare system. And in the case of behavioral health, with peer support specialists, they're folks that have actually lived and had lived experience mental illness and or substance use disorder in their life. And being able to, one of the problems in those, in making sure that health systems can have folks that come from the same community, speak the same language, have shared experience with some of the patients or clients that they are taking care of, is that you have to be able to pay those workers for their services. And so we have worked on the policy level of trying to say it is important to make sure that the Medi-Cal system finance and actually reimburse for this really important group of workers in the workforce as one example. We're also evaluating a big program of community health workers that is happening out of Washington. That is with groups of community health workers that are being employed all around the country. So that's an example of working on the provider side.
And the nurses, it's a huge issue. Healthcare workforce in general, but healthcare workforce, and it's international, it's everywhere. So, and the community is a nice segue. A couple of things that Rachel said that I think also apply internationally when she said she's listening and talking to the providers in the communities. That's what we're trying to do in our international programs as well. And what we're really trying to do is no longer manage the programs from our US offices, because it would be like me when I graduated from college and they gave me a job in Indonesia. What did I know? And what do I know about healthcare systems in Zambia or Zimbabwe or Laos that the people there closest to the communities being served don't know better, that the doctors and the local context are not more important. And that's really the move. That's the strategy for JSI's international programs, is to move power from the US to the places where the work is being done. Because you all know, if you parachute in with a program and then leave, it's not sustainable. And the learnings are never shared. And so that's really my goal, and I've only been at JSI for a year, but really to think about our international programs the way Rachel described our domestic programs, listening to the expertise and recognizing the value of contextual knowledge. And that is what we're trying to do in all these countries. I'm going to give you a couple of examples. We have a program called Reimagining Technical Assistance. So capacity building here, technical assistance abroad, funded by the Gates program. And it's all about shifting power. So shifting decision-making power from me or the offices where I sit to, or people that report to me, to the places, the governments, the communities, to set the agendas, make the decisions, figure out how to hire, who to hire, and what to do, be much more iterative, human-centered design. You have to listen to the communities. You can't be making these programs up in Washington and then, one size fits all parachuting in. So this is some of the stuff that we're thinking about as an organization. I wanted to give you just a flavor for my life. So last week, this is Malawi. This is the road from the capital city to the city where I have 31 colleagues in a city that is served on the other side of this road. This is the aftermath of Cyclone Crotty. That is just the floods that cut that road in half. So, yeah, so that's why, come on, the wimpy people who didn't show up. I'm just kidding. But, this was the most intense in the history of recorded storms, the longest and the most intense. It got powerful and came back twice. So now think of, we couldn't find on Friday, This is just my life. On Friday, we couldn't find the 31st person, and we found them. We just didn't know where they were. We also do, we have 7 other people in Malawi at JSI who are working on immunization supply chain, trying to get vaccines from one side of this to the other side. So think of the intersection of climate change and supply chain. These are the issues that are so complicated. You have to be iterative. You have to have data. So that's, I want to talk a little bit about Ethiopia because we have almost 600 people in Ethiopia working almost 80% of them are working on data, digital health information systems. And I think this is such interesting work. So we have 2 big centers that do, one of them is called CHISU. It's a project, Community Health Information Systems and Data Use. The D is silent. It's working in 15 countries around the world, from everything from broadband to national data centers. We have something called the Digital Health Center that has several projects in Ethiopia. And Ethiopia is a place very close to my heart because I worked there when I worked for Save the Children. At one point, I ran Save the Children's maternal and child health survival campaign. And I worked with what they call health extension workers, which are the community health workers. So this is like, I don't know, 15, 16, 17 years ago. And the health extension workers in Indonesia are almost all women. And when I was working for Save the Children, we were working on their training materials, and they were all paper-based, and we were trying to reduce child deaths. And so we worked with the Ministry of Health, which was at that point run by Dr. Tedros, who is now the head of the World Health Organization. I got to meet him once. It's like being with a movie star. And anyway, so I worked with the health extension workers. They're 18 years old, sometimes young, not trained, not medical school, no nursing school. So, we were doing paper-based training. And now this is the list of patients in a district of families served in a health extension post. This is me being shown the before, and this is the after. So JSI worked with the Ministry of Health in Ethiopia to develop something called the E-Community Health Information System. If you say ECHIS, then everybody knows that you don't know what you're talking about. It's ECHIS. I don't know why. But we give tablets to those health extension workers, and they can use them to not only record what they see, but also it feeds them information, it feeds them recommendations, and most of all, it gives them confidence. So here you see, our health extension workers posing for a picture because they have these programs. The biggest problem is access to the cloud, which is not consistent. This is the health extension worker showing me their programming. It's so inspiring to see this. Even the healthcare workers that in the United States don't have programs across the whole country like this. And then they're talking to pharmacists. So the pharmacists are able to make sure that they're stocking the right medicines, and at different posts, they can see the usage of different medicines. And so it hooks into our supply chain work. So this is my favorite. I think it's a beautiful picture that our photographer took. But it just shows a healthcare worker in the deepest of, a village somewhere, the last mile health in Ethiopia. This is a mother, probably a lactating mother, getting postpartum care from a community health worker. And my favorite part, see that man in the background? And just think about what's going on in that photo and why this woman may or may not have accessed care. With the guy in the background being like, curious. So I just think it's such a beautiful photograph of a woman reaching another woman in a place where she might not have been able to access care, and she can bring her tablet and make sure that that woman is counted, recorded, and gets recommendations for her care. It's a really, really good question. These big programs are mostly funded by entirely in Ethiopia, funded by the U.S. government. So we work with the CDC to some extent in Ethiopia. They're actually funding one of these programs. And then USAID, which is the United States Agency for International Development. Super problematic, but it's the United States, part of the State Department. It's the United States way of giving, international aid. Oh, enormous. And that's actually a really good question because the proposals and the bids, like Rachel said, just worked on this really big one. These are enormous work, pieces of work. And we compete, we're really competitive. And you have to bid the key personnel. You have to know who's going to do the work. You have to have a budget. You have to have experience. And so, yeah, they're really, really competitive. So USAID, all of that money is allocated by Congress. So that's really interesting to think about. And then they put out different projects, and we bid for them. One of the biggest programs of USAID is PEPFAR, which is just celebrating its 20th anniversary. And that's the George Bush's AIDS relief program that started 20 years ago, George W. Bush. There's a thing in the paper today, in the New York Times today or yesterday by Nicholas Kristof, and he said it's one of the best pieces of health policy ever. And he said, I'm giving George W. Bush credit for the best health policy, but he makes a pretty compelling argument that PEPFAR has been one of the most effective AIDS relief programs. And so that's funded by USAID. So we're a big USAID vendor, and these projects are big. They're, hundreds of millions of dollars, sometimes over 4, 5, 6 years. And Zambia is actually our biggest USAID funded country. We have 2 big programs there, both PEPFAR funded. We have 1,400 people in Zambia who work for JSI, funded by the US government. Super problematic, right? Because, the US government has all sorts of biases in the way they run programs and the way we then run their programs. But we do unbelievably strong implementation work of these large scale projects. And that's a really important skill set. What USAID is trying to do is give more money to local organizations, so less to organizations like ours and more to a local organization in Zambia, run by Zambians, registered in Zambia. But there aren't a lot of organizations that can run these, multi-million, tens of millions of dollars a year, large-scale implementation programs. So our big... that's a really sort of good question. And the answer is sometimes. And that's really the sort of next level of impact, right? Sometimes the government has to have skin in the game. Sometimes there's a consortium. So yes, but we always work in partnership with the government. So this is the Zambian president in both. The woman here on the left is one of the most inspiring people I've ever worked with anywhere, in any job, anywhere in the world. Her name is Muka Shikuba, and she runs our Zambia program. She's extraordinary. She's a famous infectious diseases doctor in Zambia, and she runs our programs there. But you can see she knows the president. The president came to our programs because we got Zambia to 85% COVID vaccination rate. So some of the countries where we work have better outcomes than we have here in the United States. So he supports us. He knows us. Having his support is really helpful. The provincial governments all support us. We work, as Rachel said, listening to the people on the ground, trying to be iterative. And we're really working on this, trying to be, much more human-centered design focused, thinking about what really works, what doesn't work. You can't come in, with a preset agenda and say one size fits all. So you really need that interaction. So Zambia, we do all of the community. So by the way, the way you get to vaccination rates like that is you have community healthcare workers out there, literally traveling in all the provinces to all the villages, convincing people to get vaccinated. And we had that infrastructure from our PEPFAR work, from our HIV work. And so in many countries, the HIV work was really useful for COVID vaccination. And we do a lot of supply chain. So we procure all of those tests. We bring them from all over the world. We procure the vaccines. We move them around the world. We deal with the cold storage. All of that JSI does, and it's all really data driven. And I know we're going late, so I want to do 2 quick things and talk about supply chain, and then have just a couple minutes at the end. In Burkina Faso, we did a really cool thing It's called One Health. We built an interoperability system for the Ministry of Health, the Ministry of the Environment, and the Ministry of Animal and Fisheries Resources. Why is that important, you ask? Those three data systems didn't talk to each other. So we built a system. This is better than we have in the United States. So, for example, there were cattle deaths, so cows dying in one part of Burkina Faso. You could see that and you could address it and figure out what that was and stop a pandemic just because you have that data. And we built that, that interoperability as part of our data work. Okay, so this is, I put this in here on purpose. So on the top, you see the three white people, me included. We work here in the United States. And then you see these extraordinary leaders, extraordinary leaders. So Muka, the second woman there is Pamela. She runs our program in Uganda. Again, just an extraordinarily well-respected, people who are texting the ministers of health in their countries. Then Henry is next to me. I was in Ghana with him, and the Minister of Health is like, Henry, you didn't come to my meeting this morning. And he's like, well, she was here, meaning me. And he's like, but I needed you at my meeting. And so that was the Minister of Health saying, Henry, I depended on you. You're my guy in infectious diseases. So just the level of expertise, the level of talent that we have is extraordinary. Actually, the woman in the back there is our colleague here in Washington. She's our chief of staff. And then in red, because it was World AIDS Day, Kate Onyejekwe, who also works in Washington, she's Nigerian and ran a bunch of programs there. And then I put this is John Negasong, he runs PEPFAR. But I put this here because I get to go and be at the fun events with Fauci. I get to go and say thank you for the honors that JSI gets, but it's really the people above who are doing the work. And there's a real tension, and I think about that every day. I'm overhead, and these are the real experts doing the real work. And it's a tension that I feel all the time. Okay, Kenya, and then I'm gonna stop. The reason I put Kenya up here is because we have some of our best supply chain work is done in Kenya. We do supply chain all over the world. We actually have a subsidiary called the Partnership for Supply Chain Management that does about $500 million a year of supply chain work. So we move around HIV tests, we move around COVID tests, vaccines, treatments, all of the paraphernalia you need for that, and 4,000 other health SKUs, so healthcare products, and we move them around the world, but mostly HIV and COVID the last 2 years. That's funded by the Global Fund, which the United States government is a big donor to. So in Kenya, we have an affiliate, a JSI organization called InSupply. This is the staff. They're all Kenyan. This is the before. These are just beautiful pictures. So this is a woman going, a health extension worker. In Kenya, they're called healthcare volunteers, community health volunteers. And she's going with her big book, taking stock of what they need. And this is the after. So in Kenya, we started something called C-Stock. And this is, it looks posed, but it's actually the actual program showing the supplies in the different health posts. And now you see these are the healthcare workers on their flip phones. And they're really all about human-centered design. So you can design a program and then you get there and you're like, oh, but they don't have smartphones. Oh, but they have low literacy rates. Oh, wait, they have low smartphone use or low data or low connectivity. And we didn't think of that. So the iterative process and really human-centered design focus is how we've built this system in Kenya. So moving around all the health products. Oh, yeah. It's such a good question. And so in Ethiopia, do you know that some of the money that we get, I keep forgetting about that, and some of the money that we get, we actually give directly to Google Cloud because they don't want Ethiopian birr. It's not a hard currency. So the US dollars goes directly to the cloud providers because Ethiopia has, actually, I think they just got a second provider, but they had, up until very recently, only one government-controlled Wi-Fi provider, and they can turn it off or it can be damaged. It's not, so there's real issues, and you have to take that into account, right? So the healthcare workers in Ethiopia, it's not always instantaneous. So sometimes if I'm going to send, you a note and say, I've got to refer a patient, you're not going to get it right away until I actually have connectivity. Oh, and then you have to have connectivity to download the message. So it's a real problem. It's a real, but what we've done, there's all sorts of solutions. The instantaneous part, you can't. In Kenya, for example, they can take a photograph of a health record, and it'll instantaneously, put in the data, so you don't have to do all the data entry, so that it's faster. But we have to have all sorts of workarounds. You have charging stations. We have solar powered charging stations. We have in many places we have. What do you call those battery things that when there's a storm? A generator. We buy generators and you need them for the health posts too. You need to have generators. So a lot of our money goes to things like generators. But if you don't have human-centered design and you create a program that doesn't take that stuff into account, it's going to fail. So you have to have that iteration. That's exactly what human-centered design is. And the idea that this original program was built for smartphones, and then they say, oh no, but look, she's just got a flip phone and she's doing an inventory of the health posts with her flip phone. And they can put the data in and then upload it later. You don't have to have it all the time connected. And that was an innovation because they assumed connectivity and so all sorts of things like that. But who they're talking to, here's the pharmacist. And by the way, the biggest part I was with a colleague who's actually the COO of InSupply, our Kenyan affiliate, last week, and she was like, it's like milk. If I have milk in my refrigerator, I have enough milk for my 2 kids, and then you come over, you bring your 3 kids, you drink my milk. I didn't plan for that. Now I don't have enough milk, or the milk that I'm going to get is now expired. It's just like vaccines. So how do you plan for that? How do you measure, and how do you know when something different happens? This is where AI is going to be really important too, is to think through patterns. But now my milk is gone. And how do I get enough milk for the next couple of days? Because I didn't plan for that. Those are the challenges of supply chain. So you've got to have, constant data and be looking at data trends. And if you see one health post is, why are they using so much of some certain medicine? What's happening? What could be happening? Well, maybe there's a bigger incidence or maybe it's being sold on the black market, or maybe somebody's stealing it, or maybe it's not, then you go and actually lock it up and you start seeing it, but these are real pictures, actually. They look so posed. But this is on the other side, you see, the provincial pharmacists who are able to track the data, because it's all on that C-stock system. So this is my last slide, at exactly 8 o'clock, but these are, the many different parts of the supply chain system that we manage all of. I think this is so cool. It's something that I didn't know a lot about, but I still don't know very much about. We have incredible experts in supply chain, but it's everything from procuring, and then sort of knowing, making sure it's on the right ship and the right container, the right truck, the right warehouse, then the right, next post, and then delivering. These are things we've delivered